But I wanted to introduce Dianne, and she has years of experience nationwide working in the area of addiction and treatment, and now she's with the Department of Corrections in Minnesota. So here you go.
Thank you. Got to figure out how to work this stuff. So I'm Dianne Seger, and I think what I can bring to the discussion here is a couple of connections. I have worked for the Department of Corrections for about the past 7.5 years, but I'm very old, and I've been working in the chemical dependency treatment world for probably more than 20 years before that. And so when I was first contacted about this forum and I started thinking about it, on the one hand, part of what I oversee in the Department of Corrections is the chemical dependency treatment provision of services for the incarcerated adult population and juveniles. But in my previous lives, I have been a clinical manager, for instance, of an adolescent treatment center for adolescents and young adults, Hazelden Center for Youth and Families, where we had kids in residential treatment for addiction disorders as young as 14. And so there's both this chemical health issue in the kids, and I have gray hair, so I can call teenagers kids. I just want to let you know that. And then there's the substance use disorders, of course, among the incarcerated population. So I work for the state prison system. Everybody kind of knows where they are and what they are. And this is, and I don't work for jails, right? So I think this audience probably is aware of the difference between the state prison system and jails. No? Okay, so I'm not going to read the slide to you. You can kind of take a look at it yourself. But there's a more diverse population in the jails in the sense that there are people who have maybe just been arrested or haven't been convicted of anything, and and it also includes people whose sentences are fairly short term. It's got to be a year or less, versus the prison system, which is felony post adjudication or post-conviction and so on. And so even the resources in the two places are quite different. So one of the first connections I want to make for you is that there is a very strong connection between substance use disorders and crime. Now that might be a well-duh in some ways because we think of DWIs or convictions for manufacturing meth or selling drugs or something like that. But there are some indirect ones as well. Violence, domestic violence, the kind of decision-making that people do when they're under the influence of a mood-altering drug as opposed to not, that may have nothing specifically to do with drugs. I think Gina mentioned this, 85 to 90% of our incarcerated population has a substance use disorder. And so this is the incarcerated population in the prison, the places that I work. And I think, I haven't read the statistics lately, but I think in the general population, 10-15% of adult people in the United States have substance use disorder or have had. That may have changed a little bit with the opiate crisis we're in lately, I'm not quite sure. But so the Department of Corrections is the biggest treatment provider in the state. We have over 900 residential treatment beds, and we have the luxury, frankly, of working with folks for a very long time, 6, 7, 8 months in chemical dependency treatment. Coming from the 28-day model, it really is a luxury, and it's a really opportunity to help people change their lives around. And it's 900 treatment beds. I mean, sometimes I say we have more treatment. We're the biggest treatment provider in the world. I'm not quite sure about that. The other thing we know about the chemical dependency treatment that we provide in the prison is that it is effective at reducing recidivism. We've got studies that actually have measured the statistical significance of a reduction along 3 measures: rearrest, reconviction, and reincarceration for a new offense. So when people who are incarcerated in the prison system complete chemical dependency treatment, they are statistically by quite a bit less likely to end up coming back to prison, which is, of course, what is always our goal. I want to talk for a minute. I don't want to insult anybody's intelligence, but I just want to talk for a minute about the nature of addiction. I've got a yardstick here. Everybody can see it, right? Yeah? Or what are you using? No. So on one end of the yard, when we talk about substance use disorders or chemical dependency, and there's some change in the language, on the one end of the yardstick, sometime in a person's life, they first use a mood-altering substance. Now that could be when they're 10, 11, 12, 13, somebody had a joint, they're curious. I mean, why do we ever do anything new? It's probably because of curiosity. It may be a sip out of an adult's beer at home when you're a toddler. Yeah, it's a thing, it happens. But there's something about the ingestion of mood-altering substances that is reinforcing in some way. So if you travel down over time down that yardstick, over somewhere in the middle to the other side, you have what might be called full-blown addiction. That's kind of a loose term. But there was dozens of times when I was working with youth in chemical dependency treatment that people would say, you know, really tell me the truth. I mean, at 14, can they be a full-blown addict? You know, I know they're impulsive and I know they make mistakes and they might have negative influences from peers and stuff, but can they really, really be an addict? And I'm here to tell you they can. And when you talk about addiction, when you talk about that kind of end of the yardstick, it is no longer just making bad decisions. There's biology involved. We've already talked a little bit about heredity. So there's a connection between substance abuse and crime, and there's also an intergenerational connection in terms of a predisposition for substance use disorders. And all of that, we've heard some of that from both of the previous speakers. But when you start thinking about what addiction is, there's biology involved. There's changes in the brain. There's an inability to, or an impaired ability to learn from experience, particularly experience that is emotionally laden. When a person starts using, it may be to socialize, it may be to get high, it may be to party with friends, just because they're curious. But eventually, this idea of neuroadaptation is really important. After a while, it takes the ingestion of the substance just to feel normal. The absence of it hurts. This is a graphic that actually shows, it's a PET scan that is actually showing the brain of a person who is not under the influence of anything and is completely detoxed, but used to use cocaine. And so this person, on the one hand, is being shown a nature video. And when you think about the neural reward pathway in the brain, you know, all the serotonin and dopamine and the neurotransmitters that make you feel good, and that's what's going on when you look at videos of a kitty and, you know, a nice sunset and all of that kind of stuff. But this is an actual PET scan of a person, the way their amygdala, the pleasure system, lights up when they are shown actually a video of things like needles and powder and stuff like that, actually the paraphernalia associated with cocaine. So what you're seeing here is kind of what happens on the neurological level of what craving is. This is a scan of 2 weeks after methamphetamine use, and this is a brain that is showing the lack of oxygen to the brain. So addiction isn't just all in your head, and it isn't, it isn't a psychological, it's also physical. The kids I used to work with used to talk about tissue hunger, like the cells of the body actually craving the drug. It isn't just, I want ice cream. It's really like my body hurts when I don't have it. And so when you think about, it's been said early onset is also predictive of addiction. So something we know now, we used to, 10, 15, 20 years ago, we thought, girls are grown up at about 16 and boys at about 18. They reach their full height around then, and girls are a little bit ahead of boys, so those must be adults then. I mean, we've even got social norms about legal adulthood being at 18 and stuff. What we know now is the brain is growing until actually maturing until about 24, maybe even 25. And one of the last things to develop is the prefrontal cortex. And that's really important when you're looking at precursors to addiction, because the prefrontal cortex is the seat of reasoning and the ability to imagine an outcome, make a choice, think it through. It's really a mature brain that this capacity only develops fairly late in adolescence and early adulthood. So when, just imagine the impact of a substance on a developing brain. It's almost like the continued use of substances supersedes survival itself. Somebody who's on a run or somebody who's drinking or drugging, the continued use of that substance is almost perceived as survival itself. So what will go by the wayside is things like food, clothing, and shelter will become optional. The drive to procreate, none of that will matter, only the continued use of the drug. And the addiction really, the urge to use really starts coming out rather than the cerebral cortex, the reasoning part of the brain, out of the hypothalamic limbic system. So it's almost like a biological reaction, like a fight or flight response. You know the experience when you put your finger on something really hot and your finger pulls back a tiny fraction of a second before your brain even says hot, right? You don't think about pulling the finger back. The finger comes back and then it's like, ooh, that hurt, and it hurt a tiny fraction of a second later. So when you think about the compulsion to use substances for an addict, it's that kind of a fight or flight response. One of my daughters, when she was about 5, discovered that I had a startle reflex. I don't know if any of you have had this, but at about 5, she figured out that if she snuck up on me and I didn't know she was coming, she could grab me from behind and say, boo, and I'd do this. Sometimes I'd even yell, you know. And that was so funny to her. And I remember saying, I'm not going to startle. I'm not going to jump. I'm not going to jump when I'm not. Have you ever tried to train your brain not to have a fight or flight response? It doesn't work. And that's what addiction is for an addict. So I think I've kind of covered most of this. I'll just give you a chance to review it. Again, I'm talking, the slide kind of refers to what I've been talking about the structural changes in the brain and the functional changes in the brain that come with addiction. Now let's talk about the kids. They don't all show up really showing what they need. And so getting back to the substance use disorders among children of incarcerated parents, you know, there's all kinds of things out there that will, you know, lists of symptoms and how do you tell when a kid's in trouble with drugs or alcohol. I'm not going to go into that at length, but I guess the last connection I kind of want to make is with young people, don't ever assume that you know where on the yardstick they are, because they might be in a very different place. And so a thorough assessment, understanding their needs and so on, whether they are the children of incarcerated parents or not, they can absolutely have full-blown addiction issues, and we can't treat them well if we don't understand the depth of their need. So they are our greatest resource, and I guess with that I will pass.